And we really appreciate the Down Syndrome Connection in the Bay Area for having us. If you have any questions, we'll be doing kind of a Q&A at the end. So please submit any questions you have in the Q&A box, and we'll be reviewing those at the end. So thank you so much. All right, Marianne, are we all right to start?
Yes, Bryn, go ahead.
All right, great. Okay, well, welcome everyone. Thank you so much. You are attending the global webinar publication of the first evidence-based medical care guidelines for adults with Down syndrome, that we are really excited to be joining the Down Syndrome Connection of the Bay Area today. My name is Bryn Gilero. Dr. McGuire will be introducing himself, and I'll be introducing myself a little bit later. But just thank you for having us and for joining us today. So again, thank you for being here. We're going to first just go over, a little bit of the agenda. We'll go over a brief overview of Global and our work, what we've been doing during COVID. And Dr. McGuire will then go over some of his work and what he's been doing during COVID. And then we will share more about the Global Medical Care Guidelines for Adults with Down Syndrome, which were just published in October officially. And we'll share a little bit of the process behind those and how they were created and who was involved in that process. And we'll also then share where we're going from here, some of the plans for the future, and how families and providers can get involved and can make sure that you're accessing and using the guidelines. And then we'll do a Q&A at the end for any of your questions. As a reminder, neither myself nor Dr. McGuire are medical doctors, and so none of this is medical advice. And we hope that you have a great doctor that you use. If you don't, please reach out to Global. We have lists of medical providers across the US and Down syndrome clinics that may be in your area. If anything here resonates with you, consult your medical provider or your behavioral health specialist. And then I will just, as an additional aside, I will just say, for the Q&A, we are eager to see your questions and to help maybe guide you to some resources. We are unable to answer any kind of specific questions about specific individuals, including behavioral health related questions even. So please reach out to us individually offline afterwards if you have any specific questions regarding your specific adult with Down syndrome. So by way of introduction, my name is Bryn Gilero, and I am the Director of Adult Initiatives for the Global Down Syndrome Foundation, going on my 6th year now. And my background is really in psychology and social work. And my introduction to the world of Down syndrome was really, I was fortunate enough in college to work in group homes, just providing direct care support. And then in graduate school, I completed my graduate training at the Adult Down Syndrome Center in Chicago, which Dr. McGuire will share a little bit more about. And that's how I found my way to Global, as they were expanding from this incredible research and pediatric focused care into adult focused care. So that's where I've been for the last 6 years. Who is the Global Down Syndrome Foundation? For those of you who don't know, I'll just give a little bit of background. Here we have our fabulous CEO and president, Michelle C. Whitten, and her husband, Tom. And the inspiration behind Global was really her amazing daughter, Sophia. And of course, there's her son, Patrick. And Sophia happens to have Down syndrome. And their family, together with her parents, Anna and John J.C., provided the lead gift to start the Global Down Syndrome Foundation. And the Global Down Syndrome Foundation was really started to answer a need that was raised by these two apparent situations. As Sophia was born, one was that Michelle realized there was a different disease spectrum for people with Down syndrome compared to the typical population. And what this means is that they seem to have a higher likelihood of experiencing certain medical conditions like autism and Alzheimer's and autoimmune conditions. And then they seem to be really protected from other conditions like heart disease and cancer. So what was apparent is that there was this need for unique medical care to address this different disease spectrum. And at the same time, in addition to this need for unique medical care, there was what we consider a life-threatening disparity in funding for Down syndrome research. So the funding dollars just were not there. So we, Michelle knew that in order to address this well, we started the Global Down Syndrome Foundation, which is an affiliate model that works with our medical affiliates, our pediatric C-Center providing care for children with Down syndrome, and our adult pilot clinic, as well as our research affiliates, which is our Cernic Institute and the Rocky Mountain Alzheimer's Disease Center, which is now called the Alzheimer's Cognition Center of the Rockies. I think they just changed it in the fall. And so we also then, of course, work with Congress to advocate on behalf of people with Down syndrome, work with NIH. I'll share a little bit more of that later. And then we have a membership program of over 100 local Down syndrome organizations across the US. And we all work together for the benefit of people with Down syndrome. Again, just digging a little bit more into that affiliate model and how we work together, some really incredible accomplishments from our Pediatric Down Syndrome Center, the C-Center here in Colorado. We're close to 2,000 unique patients now from 28 states and 10 countries, which is really fantastic. We have first of kind clinics in the US, including our mental wellness clinic and sleep clinic and school age clinic. So people come from all over the world for that care. They specialize in aspiration and spasms and autism. And so we're really fortunate to have that here in our backyard. And they also then, of course, do research as well there. And we, oops. And then, of course, our research and advocacy, here we have this fabulous picture of Frank Stevens at the first ever congressional hearing for Down syndrome research, which was organized by Global and resulted in a tripling of the NIH budget, which was really for Down syndrome, which is really historic. And as you can see here, has continued to grow over the past 4 years now. So, in 2016, $27 million. Last year, over $113 million from NIH for Down syndrome specific research. So Global has, those two needs that they identified of the medical care and the research. We are delivering on those goals. And when we started, there was one researcher doing research on Down syndrome on the Anschutz campus. There is now at the Linda Cernic Institute, there are now over 200 scientists doing Down syndrome research. And so, some of that work, and I won't read through this whole thing, but some of that work includes, JAK inhibitors and identifying Down syndrome as an autoimmune condition, which is really interesting research. And so I hope that you all check that out. We will be giving these slides so you can read more about that. And then we also have listed here some of our NIH funded clinical trial, which is up and going now on JAK inhibitors in people with Down syndrome. And so really encourage everyone to take a closer look at that. And here you might have heard some of our work, the Human Trisome Project, the biobank for people with Down syndrome, as well as as I was just mentioning, our new clinical trial. So you'll have that information here. What have we been doing during COVID? Unfortunately, like so many of you, COVID took many of our plans and we had to shift and pivot because the needs in our community changed dramatically. And so we've been working really hard with our medical experts and our families and our staff to rise to the challenge and fill those needs. And some of the ways we've done that, we pivoted and we made Global gives grants every year for our members, and they're usually educational grants and employment grants. And this year we decided to make those COVID relief grants for families. So we were able to serve over 140 families with our COVID relief grants. With 6 other national organizations, we were able to create the Down syndrome and COVID-19 Q&A resource that's been used by families and providers to to better understand how Down syndrome and COVID, how to protect our families with Down syndrome from COVID, what may be unique about people with Down syndrome in regards to COVID. And we are currently working on a new update it'll be more likely February of this year, which will talk a lot more about the vaccine and testing and all those advancements. We were also able to provide protective equipment, PPE, to masks and gowns to all of the group homes in Colorado, which was really incredible. They did not have access to that care. And then we've been working to fight discrimination in medical care through the triaging and which was discriminating against people with disabilities in many states. And so Colorado really led that charge, and Global was part of organizing over 140 of those organizations who worked on that. So that's kind of what we've been doing during COVID, in addition to the medical care guidelines, which we will be getting to.
And my name is Dennis McGuire, and I am with my colleague, Dr. Coyne, we started the clinic in Chicago. Thank you, Bren, by the way, I appreciate it. And we wrote a couple of books. The current mental wellness book is we're in the process of having a second edition. This book is your book because it was based on what we heard and learned from the families. We call this the Bank of Family Wisdom, and it should be available to you. But I'm a senior consultant for Global because I'm senior. I'm an old guy, and there's some advantages to being an old guy. But okay, next. For 27 years, I've worked in clinics with my colleague, Dr. Coyne, and Dr. Martin, who's in the lower picture there. We saw thousands of people, about 6,000 people. And it was, we call it a one-stop shop because we basically, we took care of pretty much health and behavioral health issues. And we really, the advantage of a clinic was that we were able to do primary care, and so we saw approximately 60% of these folks really had no problems whatsoever, and that was very helpful to allow us to see how adaptive and creative people are, and not just to be a place where people came with problems. And that's a huge part of our books, was really basically to describe strengths as well as weaknesses, and that's really important. Okay, next slide. So, and a big reason for our success in the clinic really is because we saw both, because I'm a social worker and Dr. Coyne a physician, and we kind of were able to see that they were very much connected. So, and meaning when people came in with a thyroid condition or depression, sometimes we would look for and become detectives looking for any other possible cause or source. And because there were, we kind of covered the whole territory, we were able to kind of identify health issues that created what sometimes looked like depression or some behavioral health issues. And vice versa, sometimes health issues would have an influence and create problems with medical problems. And so, okay. We found there were certain characteristics. We write it kind of some length in the mental wellness book, concrete versus abstract forms of thought, which is pretty, families understand that. There's some kind of funny things about asking a gentleman if he works, and he said no. And I said, well, it says you're working. And he said, yeah, silly, but I'm not working right now. So concrete is kind of funny. Expressive and receptive language is really incredibly important. Most of our guys pick up on everything around them, but they don't always know how to interpret it. And they're not necessarily the best communicators, because we described a situation we called taking the fifth. And that is simply that people don't always feel comfortable verbally expressing things, so they would often, if people would ask them, how was your day, they couldn't really explain that because they didn't feel that safe talking about it. So social emotional skills are phenomenal. Our guys are very attuned to the social world. The only problem with that is they may be a little too sensitive and can be very hurt by anger or tension in the world. Self-talk is pretty well known now, but it's still an issue for our guys. They still get in trouble out there in the community when they talk to themselves. And families are kind of terrified when they hear their son or daughter in their room talking up a storm, and we tell them that that's actually very healthy. It allows them to have their own little lab where they decide, they kind of bring in things they've encountered out in the world into their lab to make sense out of it. Because we are a mystery to them. And also groups is a pretty group-like concept, meaning it's been around for a while, and it's just this sense that people have their sense of order and repetition, and that's generally very beneficial to them. Visual cues, visual memory, it's pretty well known that people are very responsive to visual cues. What we kind of talked about at some length with the fact that people are also, they have a photographic like visual memory, and that can be very beneficial to them. But it also, because they can remember everything they see, but it also creates some problems when those things they see are problematic. And so they can, if there's a situation where they remember a past event that was negative, they could replay it as if it's happening right now. So we just we've learned all these things from the families, and that's been very helpful. There's huge onboard strengths of people. So COVID has created some unique challenges. I will send Ariane a short description of some of the things that we think could help, but routine is definitely the key, and that's built into our guys. Staying busy and active, you really have to get creative about that, but there are ways of doing it. Have your son or daughter involved in Zoom sessions or FaceTime and help maybe set them up. Find new ways to engage their peers, and use calendars and visuals. Again, there's strengths for our folks. Calendars especially, it's a way to kind of organize and manage some kind of activities. Even if people can't leave the house, they can have some kind of checklist of things that allow them to feel like their life is full, or at least more full than just sitting around. And so that's very beneficial. Okay.
So now turning our attention to the Global Medical Care Guidelines for Adults with Down Syndrome, we like to think of this as a legacy project, in that it's a legacy of health for every current adult with Down syndrome and every child with Down syndrome who will one day grow up to be an adult and utilize these guidelines. And it's also a legacy in that it's a legacy project. You know, this is, as I'll explain more, Global is in this for the long haul. This was just the first update in the first version, and we're looking forward to continuing our work on the guidelines and building on them over time. So the big question of why now, there's a real critical need for the adult guidelines right now, because what we think of, we like to call it a kind of a mini population explosion of Down syndrome. We have an increase in live births, an increase in the lifespan. And what that means is that with this longer lifespan, we need better healthcare to age in a healthy manner for our adults with Down syndrome as soon as possible. And we also, of course, then with the increase in funding from the NIH, we now have research dollars that we can apply to Down syndrome, or researchers can apply to for Down syndrome. And so what's really important is that we galvanize our researchers to apply for those dollars that Global and many other advocates have worked so hard to make available. So for some of you who have been on this journey with Global for quite some time now, you may know that we've been working on this project for, we've been working on the guidelines for about 4 years, but the notion of the guidelines and how they came to be kind of really started almost 6 years ago. And so what took so long? First of all, again, when there's not a lot of research funding dollars there's just not the money for it. So that took a long time to get the research and the advocacy in place. We don't have a lot of clinics, and so we have relatively few experts available. It took a long time to identify and have enough experts to get involved and to write these. Down syndrome is not it's not a single system condition. It's very complex. People with Down syndrome experience a lot of different medical needs, and so we needed to make sure that addressing all those takes a lot of time. And as you'll see, we had to choose which we were going to address first. And then just creating the guidelines itself requires a lot of time on part of the clinicians and the families who participate in focus groups, and even like Global and our team in just kind of organizing the project. So just time consuming and financially costs a lot as well. We wanted the best experts, as I mentioned. That took a while to get the right team and a great team together. Our lead authors include, in addition to Dr. McGuire himself, Dr. Capone from Kennedy Krieger, Dr. Peterson in Kansas, Dr. Chacoin also from the Chicago Clinic, Dr. Belova in Pittsburgh, Dr. Harville and Dr. McKelvey in Little Rock, Dr. Carl Tyler from the Cleveland Clinic, Dr. Barry Martin from right here in Denver, and then of course Michelle C. Witten from Global, and then our co-authors here in addition. And I won't go through all of our volunteers, but just so you know, in addition to the lead authors writing the document, we also then had the authors were tasked with creating volunteer committees. And you'll see many of these names may be familiar to you. For example, Dr. Espenson or Dr. Keller, and some of them may be less familiar. And that's because in building these volunteer committees, they had to recruit experts in Down syndrome and also experts in certain content areas. So while some of these individuals, for example, Joan Medlin, may be an expert in Down syndrome in their field, we also then wanted to complement that with other very, very, very specific medical areas of focus as well. And so those really supported each other. And then of course I mentioned that the financial, this was an incredible financial investment, and we did it with 50% from Global and 50% fundraised from the community. And we just wanted to thank your organization and the Connection of the Bay Area for helping us. You're one of our big supporters here, and so we thank you for that. But you can see it took quite a lot of organizations who really stepped up and said, this is important to our community and to our adults. And we also wanted to make sure we use the most advanced methodology. And I won't go into what these systems mean. So, specifically, you can read the slides on when we send them out. But something to know is that we use this system in creating the guidelines. We use PCOT questions and this grade evidence decision-making framework. And really all you need to know about these is just that these are kind of gold standard for guidelines. And we wanted to make sure that we use this type of methodology because it would make sure that what was created was trusted by the larger research and medical community. It also makes sure that the guidelines are transparent and that it creates kind of a roadmap for what we did, so that as we build on the guidelines in the future, we can look back, our experts can look back, our teams can look back and build on that work. And so these were very important to the process. And when I talk about the kind of larger research and medical community, the reasons why we want these to be trusted by that community is because there aren't many Down syndrome specific clinics across the US for adults. And so these guidelines are really for medical providers across the US who are not familiar with Down syndrome. And so we wanted to make sure that this could be trustworthy and seen as gold standard to those individuals. So here we have the result of that whole process was that all of those fabulous experts and authors got together and created a list of 40 topics that they thought were the most important for adults with Down syndrome. And the first job that the author group had was to take those topics and narrow them down to 9 initial topics to be covered in this first iteration of the guidelines. And you can see them here listed. This was a really difficult process, but as you can see, it took almost 4 years just to cover these 9 topics. We have many more topics that the authors are already really excited to get started on, and we hope to, in future iterations of the guidelines, not only build on these topic areas, but add new areas of focus, including areas like sleep apnea and cancer and other topics that are also incredibly important. But unfortunately, for the time, money, the number of experts, we had to focus on these initial 9. And I mentioned the focus groups. One thing that was really recommended to us was to organize focus groups of family members and self-advocates. And of course, that was of utmost importance to us. And in fact, we were asked to put together groups of, I think it was 10 family members, and we did 27. And so we really tried to go above and beyond and on this part, because we thought it was so important to make sure families and self-advocates thought these were helpful and useful, and that we could address those issues if there were any. And again, special thanks to Connection of the Bay Area. Your organization was really helpful in helping us recruit some of these family members. And something that was important to note about this is that over 80% of the individuals that gave us feedback on this, we worked to make sure there was an incredible range of diversity of age, gender, ethnicity. And over 80% of those respondents were incredibly satisfied with the guidelines. Not only that, but the individuals who were not satisfied, their feedback was the organization had never seen this, who helped us do this online focus group. Basically, families were using the negative emojis. These are the actual emojis that families had to use to respond to the guidelines and give their feedback. Families were using the kind of negative emojis like angry and sad and surprised and confused. They were using those because they were sad that these guidelines hadn't existed before, or they were angry that no one had ever told their doctor this information. So it was kind of this this unique situation that the focus group organizers had never seen before. And so some of the other feedback we heard from families from the situation is that we need a kind of layperson's glossary and some additional toolkits to make the guidelines easier to use for families and self-advocates. So that is part of the work that we have to do from here on out with the guidelines. So we're taking that on next. And then of course, once we have those 9 topic areas, the authors had to generate 26 different medical questions that would lead the process. And what's most important about this slide is knowing that, just to show you the real lack of research that's out there for us to use, they looked at over almost 12,000 citations and articles. And of those, only 22 studies were found to be useful and met our criteria to be used, 22. So that means that our entire guidelines had to be written based on the incredible expertise of our clinicians and these 22 studies. And the final product is what was created is 4 statements of good practice and 14 different recommendations. And so that's what you'll see here, and that what Dr. McGuire will go over in a moment. So again, this just underscores the need for more research and to continue the funding for Down syndrome research as well. So not only to inform the research, but to hopefully continue that funding.
I guess that's me. I'm still trying to get used to this whole notion that I can't see people. It's just kind of hard. But notice from this slide how many no evidence. They're in red. That is an indication of what we need to do. The good thing about all this no evidence is that it points the way to where our biggest emphasis should be. And so it's huge, huge, huge. But at least once you can at least articulate what's missing, you can begin to go there and really, and also the benefit of this is going to the federal the people who supply the grants, and they see this, and it's just much clearer. So, okay. JAMA is the Journal of the American Medical Association, highly prestigious and trusted. It reaches across disciplines. It's just a real phenomenal coup in a sense, because there's a podcast. There was just it's just a big deal, and because it puts Down syndrome on the map. It puts Down syndrome in a way that's kind of allows the federal government and researchers to kind of see that this is really important, and we have a lot of work to do. So, okay, next slide. I want to just point out these are the two areas that Bren and I looked at, behavior and dementia, that we were personally involved in. Notice there are a bunch of other areas, and obviously there's so much more, but if you go back, oh, here you go, behavior. So I want to go through this and explain this to you, the behavior. Can you go back one, Bren? Oh, okay, there you go, that's good. When concerned for mental health disorders in adults with Down syndrome, as you notice that number one behavior, we recommended then that medical professionals should refer to a clinician knowledgeable about medical mental health disorders and common behavioral characteristics of adults with Down syndrome. Now, we did that for a number of reasons. We found that even though the evidence, as you see in terms of strength, is weak because there have been so few studies in this area, there's huge clinical evidence. As we said earlier, we saw 6,000 people, and there were a couple other clinics in Ohio and Pittsburgh and different places where we saw people. So there's a strong clinical evidence based on thousands of teens and adults with Down syndrome who we saw at our clinic in Chicago. And what we found is that that clinicians who did not have experience with Down syndrome were far more likely to diagnose a normal behavior as a mental health disorder when they were not, such as self-talk or even the groove. And so we wanted to recommend that people have, whenever possible, access to some kind of mental health professional or medical professional that could actually clarify. And conversely, also, we found that many mental health disorders, when people did not have experience with Down syndrome, were often attributed to just the Down syndrome and thereby weren't treated. So this seemed to be incredibly important, and so it's why it made the cut. Also, in terms of the second issue for a behavior is that we strongly recommended the use of the Diagnostic and Statistical Manual for Mental Disorders, what we call the DSM-5, and that is the standard for diagnosing any mental health disorder in any population. And we found that our guys were that we could do that. We just had to adapt some of the criteria. And if you continue reading there, we recommended using it's called the DM-ID2, which is just a criteria used for people with intellectual disabilities as a way to kind of adapt DSM-5 to fit our guys better. Let me tell you what I mean by that. Depression, the evidence for depression is kind of interesting. That it's often, one of the indicators for depression is that people have some indication of guilt and our guys just don't. But in order to adapt the depression criteria, we found that it was pretty clear that people had a major shutdown in their interest. And so we were able to adapt these DSM-5 criteria to fit our folks. And finally, around dementia, caution is needed when diagnosing age-related Alzheimer's dementia. We found that consistently, there was strong evidence that people who were younger than 40 were not likely to have Alzheimer's. And so we recommended people focus their attention on people over 40. And secondly, the medical professionals should assess a number of key areas: cognition, behavior, communication, adaptive functioning, ambulation, motor skills, and general decline in skills, because in fact, Alzheimer's is a diagnosis of exclusion. So maybe go to the next slide, Glenn. And so again, there were weak recommendations for all of these except the dementia recommendation. But we were able to kind of keep this as in the initial guidelines because they were so important, and to kind of guide people. Just to give you an example how this could be so important. When we were in the clinic in Chicago, we used to get calls every day about some concerns that a 25-year-old had Alzheimer's dementia. And so we were able to say, look, the chance of that is really slim, given what we found, our evidence, clinical evidence, and some of the research studies. And also, we also strongly recommended that behavior and personality was not the only criteria, because that was actually two changes that we would see in every other problem area. So there's a good chance you could diagnose Alzheimer's when it didn't exist, and as a result, not really give people adequate treatment. Okay. And finally, what this really helped us understand is that we have a lot of work to do, and this guides the future. And so people are already interested in what we missed and what we need to focus on. And it also begins to give us a sense of the standard behavior assessment tools that we can begin to put together, the mental health risk factors, and co-occurring medical conditions. So it's really, the guidelines help to articulate and organize and point out future directions, and it's hugely important. Again, it kind of puts Down syndrome on the map in terms of being a priority for research and clinical practice. Finally, this is the Globalist Guideline checklist. This is a really helpful way to kind of organize the guideline recommendations. As you see, the top two that apply to Bren and I, behavior and dementia, each one of those sections, as you see it over the, it goes from 20, the top blue, 20 to 29, 30 to 30. Each one of those boxes represents a year. So every time you go and you do an assessment, a yearly assessment, you can mark off if there are any behavioral changes or indications of dementia. Notice the second one for dementia, it begins at the age of 40, which again was consistent with our recommendations that you begin to look for and assess for dementia at the age of 40. Before that, you just is not as necessary. And notice all the other areas: diabetes, cardiac, obesity. Those are all, again, key areas. And as we go back and add new guidelines in future checklists, we will have other key areas, as Brent said. Cancer, sleep apnea is huge. Some people are pretty upset with the fact that we couldn't do sleep apnea, but we really had to do a limited number in order to really get this done and out. And that was our criteria. So, okay.
Thanks, Dennis. And so I think now the big question that families and self-advocates ask is how do we access them? Where are they? As Dennis shared, the publication in JAMA was was huge, and it will be open access shortly, I believe in a few months, and we will make sure that that is available when it is time. In the meantime, we do have the link to the Jama Abstract, which is like the summary, so you can see it and it's summarized and you can access it if you're a member. So their general process is just when something is published, it's on a limited publication until it is open access. So that will be happening very soon, but it is on their website and you can see it there. You can also hear about it on their podcast. In the meantime, the full guideline is on Global's website for anyone to download and print and use. And so we do encourage you to do that. The link is here in the webinar. As I mentioned, we will be sending this to Marianne so she can get it out to anyone who's attended today. And the difference just being there, on Global's website, we have the full guideline, which is a 90-page document, which I know sounds overwhelming. It is really, please know it is written for a medical audience. And so it is for families to take to their providers and for self-advocates to take to their providers and really go through with them or review certain parts together. And so it is a long document, but we are working on additional toolkits in addition to that checklist that Dennis went through earlier. And so then you can also, on this page, we'll also have links to, you can learn more about the Cernic Institute and the Human Trisome Project, including the JAK inhibitor clinical trial that was mentioned earlier in the presentation. Here's my email as well. Please let us know if you have specific questions about the guidelines, and we will make sure that if we don't get to any questions in the Q&A, that we'll try to get those replies to Marianne in email. And so please go on Global's website and feel free to download the guidelines and use them. So what is next now that we're at this point and the guidelines have been published in JAMA, the full version's available on Global's website? What's next is, I mentioned that this is a legacy project. We still have a lot of work to do. And so right now we are working already on identifying the next areas to cover. We're continuing to fundraise and to advocate for the NIH funding for Down syndrome research, because if we need that funding pipeline for more research for our scientists. And immediately we're already starting to begin the translation process to make sure the guidelines are in many different languages so they're accessible. We are starting to add additional toolkits. The feedback from the family focus groups and self-advocate focus groups was the glossary of easy of terminology, getting kind of an easy understand checklist for each of the 9 areas, not just the full checklist, but a checklist or some sort of a tool for each area. So those are in the works and coming. And then of course, the other things that we're working on doing are webinars just like this with local Down syndrome organizations across the US to make sure that families know the guidelines are now available, to make sure they know how to access them. And then our medical doctors, the authors, they're working on, many of them are doing grand rounds and presentations to their institutions and hospitals, which is incredibly helpful because we need to make sure that medical providers know how to provide good care to our adults with Down syndrome. Those translations, as I mentioned, here are just some of the 17 languages that we've kind of targeted, and these are based on many different things: population size, relationships with organizations in those countries, and just the need. And so we're working on it, and it won't be all 17 at once, but we hope to slowly get there over time and have at least a few finished in the next year or two. And so just here's that timeline again. Obviously October 2020 published in JAMA, that was huge. And while I wish that was kind of the goal was really, that was really just the starting line. So now we are currently, as I mentioned, working on the translations and these additional toolkits, as well as kind of bolstering the current guidelines and adding new topics with the hopes that by 2026, so again, we're on this 5 years, kind of 5-year work period, 6-year publish a new updated guideline. So that's where we're at. And families who want to help and get involved, you can use the checklist You can send the guidelines to your medical providers, participate. Global does surveys and different advocacy events, participate in those, and of course, helping to underwrite the work if you can. And we are just so appreciative of everyone's efforts on this, and we thank you to the Down Syndrome Connection of the Bay Area for supporting our focus groups as well as the guidelines themselves and having us here today. And we would be happy to, I think we have just over 10 minutes here for some Q&A, so we'd love to hear from you if you have any questions or any thoughts on what some of the next focus topics, medical topics you want us to cover. You know, drop that into the Q&A or the chat box. We'd love to hear from you.
So Bryn, can you read those? Do you want me to read them to you? It looks like we have a couple regarding, there's nothing in the 94-page document that addresses the pap smears and pelvic exams. Is that something that is being looked at going forward, and what can you recommend?
So I can, again, Dr. McGuire and I are not medical doctors.
Right.
I can share more about this, about the topic of cancer screenings. As you know, so the checklist address is basically what we did was we took the 94-page document and we took those 9 topic areas and we synthesized them into just the top line information and timelines for those screenings and assessments. So what is in that checklist are the 9 areas that are in the guideline. And so the current guideline does not cover cancer screenings, so pap smears and pelvic exams included. But we hope to include cancer screenings in the next iteration of the guidelines. And I know that 2 of our lead authors, Dr. Chacoin and Dr. Martin, have been doing some work around cancer screenings and cervical cancer screenings, and are excited to hopefully add that in for the next version.
Yeah.
Okay, I do see them here. So someone asked about the current status of the adult medical clinic for Global. So as we mentioned, there is an adult pilot program in Colorado for adults with Down syndrome. And it is just in its pilot phases. We're still learning and growing the program. It's 1 day a week with Denver Health and Dr. Martin providing medical care, and a wonderful licensed clinical social worker, Nina Cruchon, providing behavioral health support. And it is currently only for in-state residents. And as the clinic grows and it moves past the pilot phase, we hope to expand services and expand specialties and expand to other states. Dennis, someone asked, when do you expect the second edition of the book to be published?
February. It's
This
coming out in about 3 weeks. Yeah.
Awesome.
And Bryn, this the question about how are you getting these guidelines into the hands of docs? You have, I mean, that's a huge emphasis on this, right?
Yeah, absolutely. I think, you know, as Dennis mentioned, publishing them in JAMA was a big step to getting them out there to the general providers, since that is one of the, you know, largest distributed and well-known and reputable journals out there. We're also doing workshops like this for families. We're getting them into the hands of our local Down syndrome organizations to share with their providers, and continuing to then have our doctors do grand rounds at the institutions, which are, you know, seminars where they can share the guidelines with their providers. And so those are just a start. We hope to do work with Meg as well. So those are some ways. Anything else, Dennis?
Well, yeah, I mean, the way we found in the past was that the families, the parents would have the information and bring it to their docs. That was by far the biggest way to disseminate, by far. And because you have a huge interest, this is your kid, nobody cares more for the kid, but the doctors will actually look at what you bring them. And that's huge.
Yeah, and I think just as Dr. McGuire mentioned that, you know, they that he and Dr. Chacoin learned and used to write their book. The same goes for this. It's brought by families to their attention. And so, you know, just you printing these out and bringing them to your adult son and daughter's visit, or your self-advocate bringing them to their doctors, that would be huge. Another question here, someone said they would love to go to an adult Down syndrome clinic. How could we find one, and are they covered by medical insurance? You know, Global on their website has a resource list of clinics across the US. And we do share the organizations that have shared their insurance information with us. We do have listed on there. It just honestly, it depends on the clinic, you know, so all their contact information is on our website. I'd be happy to share that link as well with Marianne, so she can send that out. You can look up by state, the clinics in that state, and see if they're pediatric or adult, the services they provide, and then you can get their contact information for that specific information.
Right. Going back to that, how do you get information to the docs? A big part of the guidelines, because Global is, Michelle Winton is the parent, is to get the information in a form that parents can understand. And that's why that guideline, that form that evidenced all the recommendations on one sheet, that it's in a way that you can bring to your doc. So that's a huge piece of what we were trying to do, to make it accessible so you could get it to people who need to know and see it.
And Dennis, I have a question for you here. It seems the Bay Area needs a clinic for adult care.
Yeah.
Get this to happen, as you know, as someone who helped Global work towards opening an adult clinic, and who started at the Chicago clinic with from a very little office. How can, any tips for how they can get an adult care clinic to happen in the Bay Area?
You know, I think with Marianne and the whole parent group behind you, you try to go for funding, you want to locate a doc and a behavioral health person. I think you guys, you may be able to kind of pull together some kind of a response. It's not, I got to warn you, I've been doing this 40 years almost, and it's very hard. That's why there's so few clinics, because it's incredibly hard to organize a clinic, and it really, you lose money. And so that's an issue. So you have to have some additional funding, like the Down syndrome clinic in Chicago, and a commitment by a medical provider and a medical provider system. And so, you know, maybe USF or something could be on board, and that's really, but a huge piece of it is always the parent group. The energy behind the parent group always is the driving force.
This is Marianne from the Down Syndrome Connection. We've definitely been in touch with several medical facilities, and we're still pursuing it. It is an ongoing thing, but as Dennis mentioned, it is not easy. It comes down to dollars and cents, but we certainly could use all the backing from parents and
yeah.
That. So we're actively pursuing it, but it's a tough hurdle, no question about it.
Right.
Also, I noticed there was a question about whether you have thought about going after big healthcare providers like Kaiser, Sutter Health, things like that, to try to get the information out to them. Is that something that's been discussed?
I don't know, Bren, do you know what?
So at this moment, we have not done that. I think, you know, what we have found is that it's most helpful when there is someone within the organization that is a champion for our work. And so, you know, right now we're really working with, you know, our authors who are, you know, represent some of the 10 most, foremost adult Down syndrome clinics across the US, and making sure that at their institutions, that they have that information. Because I think what's hard to even, you know, kind of fathom is, even within these institutions that have these fabulous Down syndrome clinics, many of the providers there are not well versed in Down syndrome themselves. There is the one nurse practitioner or the one doctor. And so they're very siloed. And so we are currently working, we found that instead of just reaching out kind of large scale, it really helps when you have someone on the ground who is passionate about the work, and maybe they have a family member with Down syndrome and they're working with that change from the inside. And so, many of our many of our committee members and our volunteer members are members of the Down syndrome medical interest group. And so that has also been a wonderful connection and making sure,
Right.
that,
Right.
they represent clinics and
Right.
practices and hospitals across the US, and many of them are even international. So that's been a huge success as well. So that's what we've done so far. And then of course, just making sure that we continue to update our website, and we're doing more PR around it. And, we received coverage on WebMD. And so it's been really wonderful, and we're still just getting going even.
Right. And there's a question about Dr. Scottco's DSC2U. Have you seen that, Brenda? I mean, because I think he does a nice job of pulling information together and offering things, but I have not seen his online option there.
Again, I'm not a medical doctor. I'm not sure regarding the online clinic. I've not used it personally, and so I'm just not sure.
Okay.
But as I mentioned, I can definitely provide the list of clinics that Global has on their website. And these guidelines the purpose of these guidelines is really to get them into the hands of providers who don't have a lot of experience with Down syndrome, to help try to inform their care.
And there was a question also by Bonnie about, let's take her sister to a clinic about medical insurance. And we usually find that kids who are still on their parents' insurance are covered, but so many of the people who are adults, as they get older, they're covered by Medicare, and that can be incredibly helpful. At least most of the folks attending our clinic in Chicago had some kind of Medicare coverage. So it's worth pursuing that too. Anything else, folks? Are we missing any questions? I guess not.
That looks like it might be it in terms of questions. I don't see anything more trickling in. So thank you both so very much. I will get out the slideshow when I get it. This is being recorded as well. So we'll send it to a few people that signed up and were not able to come. So if that's,
Okay.
let's see, one thing just popped up real quick here. Did you answer a thyroid question? Let's see. I'm not sure what that means. Did you answer on the thyroid question? I don't see a thyroid question to even ask. Can you ask that again, Monica? I don't see the thyroid question.
I see it. It's the
Okay.
old 1999 guidelines call for both TSH and T4.
Right.
We cannot, I'm so sorry, but we're not medical docs, and it would be it just wouldn't make sense for us to do that. I mean, we can get back to you on that if that would help. We can ask our Dr.
Yeah, I
Kleiner.
think, and here is, for in regards to the question about what is in the guideline. So first of all, these guidelines are the first, they are the first set of evidence-based guidelines. We really built on the fabulous foundation created by the 1990 and the 2001 guidelines that were largely from clinician experience. And so while that was an incredibly formative beginning for these guidelines, these are the first evidence-based guidelines. And so I wouldn't say this is discarding any recommendations, but I will just say here that what we have is the thyroid recommendation here, and our guideline here recommends a weak recommendation, meaning there was not a lot of evidence available. So still not, even since 1999, there's still not a lot of available evidence, but that there was weak evidence, and it recommends every 1 to 2 years a TSH test beginning at age 21. And again, you know, as Dennis said, as Dr. McGuire said, we can't speak to that recommendation or how it came to be, but it is covered in the guidelines. And so I do encourage you to take a look at that guideline section. And if you have specific questions, please send Dr. McGuire or myself an email. We will get it to the author group. If you have specific questions about this guideline, what it means, or what it means for the in relationship to the 1999 article, we can absolutely help to get that answered for you.
Perfect. Thank you.
you.
All right. Thank you very much. I hope
Thank
everyone
you.
has a wonderful weekend, and appreciate all your hard work there.
Thank
Yes,
you,
thank
Mary
you so
Ann.
much for your support, and we will send out the PDF of the slides as well as some of the links that we mentioned to the guidelines and to the clinic listing. So thank you very much, and
Perfect. And I
thanks,
will
Dr.
forward them on.
McGuire.
Thanks,
Thank
friend.
you very much. Take care.
Bye.
Bye-bye.
Bye now.